I'd like to welcome everyone to the North American Skull-Based Society Advancing Scholarship webinar series. This is going to be our last webinar of 2024, and we're excited to have Dr. Hamid Borghe-Razavi, I may have totally messed that up, who is Associate Professor of Neurologic Surgery. He's the Director of the Brain Tumor and Pituitary Center and the Research Director of the Neuroscience Institute in Cleveland Clinic in Florida. He's going to be talking with us today about neuroanatomical research, and on our panel, I guess we have myself, Angela Richardson, Indiana University. We have Dr. Edward Kwan, Dr. Michael Ivan, and Dr. Niall London. So we're going to start with our speaker's talk.
Thank you very much. You have my voice, right?
Yes.
Perfect. Thank you so much for invitation. Really, I appreciate it. And North American Skull-Based Society has been always really my favorite society. It has been always my pleasure to serve it. And I'm going to talk about neuroanatomical research. So disclosure, but not related to this topic. I start with my journey, a little bit how I started this neuroanatomical research during my student time, residency time, fellowship time, and how it got slowly matured until now I'm able to point the view of my view in neuroanatomical research and where we are right now. So my first anatomical study was this paper. So we had an attending neuropathologist as a student. I was talking to him, and then he told me, if you want to be a neurosurgeon and you like skull-based surgery, it's better to know the petrous bone, because the petrous bone is something that's very unfamiliar area for neurosurgeons. So that was the reason that I did this study. It was too much really as a student. He told me to measure all of this. So it was like about 20 measurements. I measured it with like small metal devices, the colis, all of these things that you see. And then finally, we were able to publish this paper. So that increased my interest in skull-based surgery and how to approach the anatomical specimens, how to get familiar with measurements of the anatomical landmarks. Then I was able to publish this paper. So when I was in Münster, medical student and resident, I realized one of these approaches that I measured is very relevant to neurosurgery. One of them was, well, actually, right now also every day I see this correlation. So when you drill the asterion, the thickness of the asterion has a correlation with distance of the jugular bulb and semicircular canals. So this is very interesting, because if you are drilling and it's very thin, then your jugular bulb will be very much attached to the semicircular. And if you have a thick bone, it will be a big distance. So I was very excited with this research, and then I called it Münster correlation, because the city that I was in Germany was Münster. I loved that city. Interestingly, I presented it in North American Skull-Based Society in 2013, which was in Miami. So I flew from Germany, and then I presented the poster. And North American Skull-Based Society was much, much smaller. It was about like 300 people, 400 people probably. And I was very lonely here. No one knew me at this time. So this was my city that I called this correlation. And then the newspaper published it. They call it Ein Stück Münster im Schädel. It means in German, one piece of Münster in every skull. So that was beginning of my excitement about neuroanatomy and skull-based surgery. Then I was able to be 3 months with Professor Kawase in Japan as an exchange program between Japan and Germany. So what he told me, I told him write something for me when I was leaving the Japan. And then he wrote me this, which was very interesting. He wrote me the objective of skull-based surgery is how to remove the lesion and how to protect the CNS, and different between anatomy and surgery in how to minimize exposure in surgery and how to maximize this exposure in anatomy. Do not make unnecessary exposure. Okay, so this triggered a little bit the minimally invasive approaches in my mind. But how to maximize exposure in anatomy was technically what Professor Roton showed to us, right? It means make a big exposure in neuroanatomy, expose everything, look at all vessels, and just do your study. But the Japanese concept was a little bit different because they have a very strong art culture. So this was very interesting for me. The resident, before starting a case, they did like a small painting or drawing on the whiteboard. And when I was watching the surgery, exactly, I saw the same thing. It means they had a very nice imagination. The chief resident had a very nice imagination on what we are going to see. So if you see, this was epidermoid tumor, this was a fifth nerve, and this was a fifth nerve during the surgery. This is a trochlear nerve. Exactly, they had a trochlear nerve here, and this was the day before surgery that their chief resident did it. So this was something that I learned from Japanese culture, like painting and drawing is very important in understanding the anatomy. And interestingly, when we did the Kawase Education Day at North American Skull Society in 2023, when I contacted Professor Kawase for this day, he sent me two of us his painting. And this is amazing how he did. You see, it's 1983, and he gave me the permission to put it in a poster for his Kawase Education Day. And you see how nicely he painted, and he's a really strong artist. So I said that because this was the culture of Professor Roton plus a little bit art in anatomy. But when I went to Pittsburgh after my residency 1 year to do a skull-based to do research anatomy fellowship, and then what I learned there was a little bit different. There I learned microsurgical approach-based neuroanatomy. It means I want to focus now on supraorbital approach, or I want to focus on transnasal approach, petrosectomy through the nose. And it was some addition of endoscopic skull-based anatomy. And also the interesting thing was these different disciplines work in the lab, like ENT. Sometimes we got like maxillofacial surgeons, and then we learn also from other disciplines. And that was the difference between this and the Roton lab. If you look at this was our time there. It was like 8 years ago. This was our meetings in the afternoon, and this was like Dr. Fernandez Miranda was showing us how to dissect, and then this was he was showing us the Dolenz approach. And I gathered a little bit also from Pittsburgh. It means these are different culture of Roton Anatomy Lab plus University of Pittsburgh, which was very much toward endoscopy and then collaboration with ENT in the lab. So finally, when I wanted to get a job, I wrote a business plan for a lab. Every application that I sent for job, I said, I have a business plan for the lab. I want to establish a lab, and this is where the money coming from, and this is what I want to do the lab. I talk about research, training, innovation, education, innovation, future direction of the lab. And when I was doing this, it was like 30 pages of business proposal. When I was doing it, a lot of things came to my mind, which was interesting. So I was talking to my mentors, and I was always debating, really, is there any room to do anatomical research? If you open the Roton book, every structure is there. What should we really do? And I was thinking like, I remember when I was talking to my mentors, I said, maybe this anatomy will fade out slowly because we know already all of the structures and approaches we compare. If you look at the Journal of Neurosurgery, all approaches already compare. What should I do? And these are questions always came to my mind, like, is it worth to spend effort and money and build a lab? And what's the purpose of anatomy lab? The goal of research in neuroanatomy, is there still room to do anatomical research? And then this is the summarize of what I found based on the journey that I have, like talking to a lot of mentors and looking at the literature. And from A to H, I want to go one by one and give you an example, because these are really indications to have an anatomy lab and do the neuroanatomy research. So number A is exploring new anatomical structures. We don't believe, but there are still a lot of anatomical structure that they are hidden and we don't know about it. So now we go to the example of number A, B, C, D, up to H, and then we can get some concept of what is really now still exists in the anatomy research and what we can still do. So number A is very interesting. You saw this paper. This is a landmark paper that Professor Tatajiba from Germany, who is a very famous vestibular Schwannau surgeon, did with Professor Rotom. They call it Tübingen line. So this Tübingen line technically it was something that no one described before. This is like the vertical fibers of the dura that they attach. They are coming from the jugular foramen toward the IAC. You see they make a very nice line, and this is a very good landmark for big vestibular schwannoma when you want to drill the IAC. So they very nicely explored it and show it in over 300 cadavers and surgeries. And you see this is a very nice landmark that you can open the IAC based on that. And if you see this big vestibular schwannoma, this part of the paper, you see these vertical fibers and you see this line, and you see how nice this landmark help us where to drill the IAC. So this is an application of this anatomy. This is the structure that we didn't know about it, but in neuroanatomy they found it and Roton Lab published it. Another newer example of exploring neo-relevant anatomical structure is cavernous sinus anatomy. This is a landmark paper that Dr. Fernandez Miranda published about medial wall of the cavernous sinus and the anatomy of the ligaments. If you look at here, you can see corticoclinoid ligaments here and interclinoid ligaments here, covering between the cavernous sinus carotid and also pituitary gland. This is interesting because some people did this approach known or unknown before this paper. Sometimes we went to the cavernous sinus because the tumor brought us to the cavernous sinus, and we saw this ligament. I remember I was talking to one surgeon, and he always told me, "Oh, when I go to cavernous sinus, I see some fibrous tissues there, but I don't know really what they are." And this is what exactly you see in this. Let me show you this video. Yeah. So this is exactly what we show this cavernous sinus surgery for Cushing disease. If you see, this is the removed the tumor and now opening the cavernous wall and medial wall of the cavernous sinus. I pass forward a little bit. So when we look here, you see these ligaments, and then before doing this anatomical research, we didn't know exactly what are these tissues that we are seeing. But after this anatomy research, when we do this approach, whoever does this approach, they have a very nice understanding of the ligaments here. And you see we are slowly starting to see these ligaments, and now we know exactly what we are doing and what we are cutting and what we are expecting. You see this is one of the ligaments that we are, and this is cutting the other ligaments. But that is after this anatomical paper, we have a better understanding of it. And this is medial wall of the cavernous sinus. So number B, the second one is emphasizing the importance of known anatomical structure to improve the intraoperative judgment. Another example for this. This was superior hypophyseal artery described before. This is not a new anatomical landmark, but we were able in Pittsburgh to look at it and then see the branches. And then when we dissected, we saw one branch going to the optic nerve and the other branch goes to the pituitary gland. And we realized if you cut this optic nerve gland, there's a very high chance that you will really make the patient blind or decrease the vision. So this was a paper published at JNS, and then in one of my cases, I really experienced this. If you see this 62-year-old with periinfundibular craniopharyngioma, so you will see exactly like the paper, like the anatomy paper we published. You see the superior hypophyseal artery, and we are preserving this branch, and then we are respecting the branch going to the optic nerve, and then we can cut the branch that's going to the infundibulum. So it means this paper helped me to have a very good judgment and understanding during the surgery. Okay, number C, pushing the boundaries of established approaches. This is an example of transpetrosal petrosectomy. So we knew we are going to the nose, and then we can go even a little bit lateral, but it was not clear what are the limitations of this. If you look at here as a midline, Yeah, if you look at here as a midline, then now we are looking at the boundaries, how we can go to the petrous apex, and then we know the limitation of the petrous apex here when we drill. We know that this is inferior. Uh, this is this is the inferior petrosal sinus, and then we have the sixth nerve here as a limitation, and we can drill the petrous apex here for some pathologies. And we made it very clear uh, for the people that they want to approach the petrous apex. Let me make my laser again, then it's easier. So here again, another case example that it helped us. This is a chondrosarcoma. So now we know we can reach to this area because the carotid pushed anteriorly, and nicely we push the boundary of this approach to reach to the petrous apex. So the next indication for anatomy research. So defining limitation of the established approaches. I remember in Pittsburgh when I was talking to Paul Gardner, one time he told me, I'm doing this supraorbital approach all the time, but I don't know really what is the limit for that? How much I can reach to the cavernous sinus? Can I remove the tumors from cavernous sinus or lateral wall of the cavernous sinus with this approach? Or can I do clinoidectomy? So this triggered me to do this anatomical research. So then we defined very nicely exactly what we can see with the supraorbital approach. And we realized we can see the upper part of the cavernous sinus and also third nerve, but we are not able to see the whole cavernous sinus. So I had a case last week. It was a small olfactory meningioma growing over the time. Then I knew based on this anatomical study, I'm not able to reach here. And if I reach here is a very sharp angle, then I decided not to do supraorbital approach for this. But the other case that was lateral to the cavernous sinus based on this anatomy paper, I knew that is easier to reach to this with supraorbital approach. It means this anatomy research helped me in my practice to realize what tumor is better for which approach. So another indication for neuroanatomy research is comparison between known approaches to have optimal approach selection. So this is another work we did comparing supraorbital approach with transeyelid. It was always question in my mind why the people do supraorbital and when they choose to do transeyelid. So that's the reason we did this anatomical study, and then we described that with supraorbital approach, actually you can reach to this area, but with transeyelid you can go to the anterior temporal pole, and then even you can go a little bit higher, look up like orbitozygomatic approach. So this is a case example. I know for this I can use, this was in the paper, I can use transeyelid approach because the anterior part of the temporal lobe is involved, and this is better for transeyelid rather than transeyebrow. So the other indication for anatomy research is exploring neglected and hidden fibers tract. So this is a paper published by our current research fellow in Turkey who was with Professor Toure. So very interestingly, he showed some fibers that they never existed in the literature. First one is this fiber, golden fiber, that attached the inferior colliculus to the interpeduncular fossa. And we see that is a transverse fiber here and transverse fiber here. And the other fibers that they found is the fiber that is the border between the pons and midbrain is like a pontomesencephalic fissure. You see this fiber here, and also another fiber that showed the pons that coming to the middle cerebellar peduncle. They showed that they have superior and inferior division, and this published in Journal of Neurosurgery. I wonder always why Journal of Neurosurgery published this, because we don't know the importance of these fibers. But actually the importance of fibers in the future, because you might in the future to see some approaches, you can realize that these fibers are very important to preserve, especially when you do Pontine approaches for cavernoma or other lesions. So this is another indication for neuroanatomy research that we find hidden fibers, and also some fibers described many years ago in the literature, but there is no explanation for them. Then we can expand it. Another indication, number G, we are getting to the final part. So if we have a lab and we do neuroanatomy research, we can do some research to improve the education. So if you look at this, this is from our fellow. I removed the laser again. So he's working on making 3D presentation modalities. And if you see here, they are like the camera doing multiple pictures. And then you can bring this to this view, and then you can make the 3D available everywhere. So if you look here, you are able to see. Let me just show you here back. Yeah, I think. Yeah. So you are able to see the 3D anatomy everywhere. Then probably you don't need to go to the lab sometimes, because you see it completely the 3D anatomy based on this research that he did for the 3D modeling. So this is also another innovation that comes from neuroanatomy research. And this is another example that he's doing. If you see this one, he's using the cell phone or iPad to make the 3D pictures in the lab. This is the app that he's using and creating, and this is an example he did in our lab. So technically, he's able to, with his iPhone, going around the specimen, he's able to create a 3D model, and then it's available everywhere for you. So if you want to look at your cell phone and look at the 3D anatomy, and then you can rotate the specimen. So, and again, this is another indication for neuroanatomy research to make better visual understanding and better visual modalities for education. So
looks like we lost it for a moment. Let's just give him a second to rejoin.
In the meantime, I will say if you guys have questions, we're using the Q&A, I believe. That's where you can put them. So we can ask once he's done with his presentation.
okay, sorry. So my computer restarted at this one, but I think it's fine. I have like 3-4 more slides. So I will just summarize, and if it opens up, I will continue. So I wanted just to mention, like, these are all indication to do neuroanatomical research. And the last one I wanted to show you is some innovation that we can use in the labs. We were creating a drill for the Petros apex, and we measured all the angles of the drill through the anatomy specimens. I will show you when the computer comes up. I think we can open the discussion if you want, and then because it takes like probably 2 minutes to come back.
Those are some really good points, and I was intrigued by your business plan. How did you come up with that? Like, did you have someone you worked with? Did you cheat on
Exactly.
someone else's plan, or?
Yeah, that was interesting, because when I was applying for a job, I said I have to do something that makes me like more attractive for someone who wants to hire me, and this was, and I looked at my background. So I was not a glioma person who did like research in the lab and have PhD or something, and my background was anatomy. So I spent 1 year in anatomy lab here and another half a year there. And I said, okay, let's use my background to advertise for myself. And this is very interesting, because some chairmen are not interested at all. They didn't even want to have a lab. And some people are like 100% different. It's like totally interested, and then they
they wanted to have me as soon as possible look at the lab plan, what is exactly you are talking about, and all of this. So that was very interesting, that I see so much difference between the approach of different chairmans in different hospitals about that.
Since we're talking about the plan, can you talk a little bit more about like the financial plan and how you kind of pitched that idea?
Exactly.
What are the incomes? What are the support lines? Just for people who are interested, young people who are interested in trying to do this and replicate it on their own.
Exactly. That's a very interesting question. I think a lot of companies are interested to spend money for education. This can be a policy of the companies, and also a part of the mission of the companies. I think if you have a person who can write a grant for these companies, you can always get your devices that you need for the lab from different companies. I think the main thing is to have the interest and passion of the person to just reach out to these different companies and put together a plan for the companies, because companies want to see really someone who spend the time and invest on education and bring the fellows, but they don't want to spend money on the lab that's just sitting there and no one use it. So, and normally the companies, when they donate the instruments, and even like very expensive instruments they donate, they want to see every few years that what you have done in the lab. So sometimes they give you the instruments like endoscope, microscope, and this stuff, and then they ask you after 2-3 years what was the output, and then they extend the instrument to be in the lab. It's very hard to get grant. I think probably you know better than me. It's very hard to get grant for the lab, but I think philanthropy will help. But really, the base of the lab will be the instruments coming from the companies.
Right, and that money goes to support the supplies, but also the staff. I mean, it's important to have your research fellows and people who are interested in contributing to the research as well.
Exactly. So that money normally should come from philanthropy, because that was a great discussion that I had with my lab mentors, and really it's very hard to get a grant for the lab. There is no interest to support the lab as a grant. I mean, it's a big interest to support glioma lab, but there is no interest to support anatomy lab, interestingly. So that I'm joining. Let me just open my presentation.
Yeah, let's see the last couple slides.
Exactly, it's like 2-3 more slides. Okay, you see it now? Okay, perfect. You hear me, right?
You may have to mute your phone.
Okay, perfect. You hear me?
Yes.
Perfect. Okay, so last few slides. The last role of the lab is innovation in the lab. So we can verify our instrumental and device ideas in the lab. This was an example we did at University of Pittsburgh. It's very hard to reach to the Petros apex with the drill because of the angle of the drill. And then we were able, based on the cadaver, we were able to design at least to give the potential design for the drill to reach out the Petros apex and to be able to drill the Petros apex. So we did a CT scan of the cadaver, and so we were able to make the measurements, and we even talked to the companies how they can produce the instruments and the drills that have this angle to be able to drill the Petros apex in the transnasal approaches. So, and this was the final real angle that we figure out, and with the exact number of the angles, even for each side was different in these different cadavers. So, last thing that I wanted to discuss that Michael also asked me. So there are two concepts of neuroanatomy research fellows. One concept is like Pittsburgh or Roton Lab having multiple research fellows, non-paid, and they come and goes, and then they can have a discussion together and they have collaboration. But I think going toward the country rules and equity and all of these in the future, it won't be like that. I don't think in the future. I think we are going toward paying the research fellows, which make it more difficult. So that will be the concept of 1 year research fellow, one research fellow collaborating with our clinical fellows and postdoctoral fellows for using the mentorship. So that's exactly happening in our hospital. So this was as you see, UPMC 2016, you see, we were all collaborating together, and then it was based on our interest, we did all something, and then we published and produced. But now this is the AI generated pictures. I think the future will be like research fellow, clinical fellow, and postdoctoral fellow working together with a mentor. And this should be a paid fellow, having a curriculum and graduation, and be like in alumni. So if you see, I summarize here the philosophy of the lab is one of them is meticulous anatomical microdissection to better understand the complex anatomy of the skull base. Obviously, improve surgical skills, one of the goals of the lab, and trigger research ideas and innovation, and as I explained. And also, my conclusion is there are multiple research and innovation opportunities still in neuroanatomy. Research fellow, clinical fellow, and postdoc researchers work together with the mentor to create and process the idea. So this is how it works in our center. So we have really every year one graduation from our clinical fellow and research fellow together through the year, through the academic year. The research fellow works with the clinical fellow together very closely, and with our postdoctoral research fellow, and they produce ideas, they discuss, and then we and my our chairman, my mentor, my partner, Dr. Allah, we mentor them, and then they graduate, and then the next fellow comes. So and then I appreciate their help, because this is the base of what we do. Our research fellow, our postdoctoral research fellow, and also our clinical fellow, they work together. And as I said, this is a concept. This will be probably the future concept, rather than having like multiple research fellow, non-paid research fellows. So I appreciate and I'm really sorry for what happened, but it happened, just my computer restarted suddenly. So I stop sharing, then we can have some discussions.
I think one question trainees often struggle with is how to come up with a good neuroanatomical research question. Do you have any advice for that?
So I think what happened to us was very interesting. When I came to Pittsburgh, I remember Dr. Fernandez Miranda gave me, like, he told me, okay, you graduated from residency, you have 6 weeks to think about something that has been your question always, and then bring it here, and then I help you to just make it like a nicer idea, and based on my experience, I can tell you if it's something that it will be like really interesting for the audience and interesting for the literature or not. So I remember I wrote like 5-6 ideas, and then he said, okay, this is probably based on my experience not interesting, but this is something that we can work on it. And I think this should be really collaboration between research fellow, clinical fellow, and mentors. Obviously, research fellow should have some background of anatomy. I wouldn't. It's very hard to have someone from like zero background of anatomy come to the lab and work, because I think it's a lot of waste of time and effort. I think that people really should show first some interest that they had during their residency, and then when they come to the lab, they don't start from zero. And I think it's just discussion of different people that an experienced surgeon. I mean, when you are experienced surgeon, you always have some question, and you can talk to a research fellow and then ask him to do some dissections and see, and then again discuss it with you, and then back and forth until it comes up as a nice idea.
Yeah, no, great talk. And just to build on that, it's tough because there's so much literature out there. I mean, obviously, the Roten works are like, the Bible of this kind of stuff, but it is sometimes hard to kind of search through all of it to find out what hasn't been talked about or what aspects hasn't been talked about, and how to comprehend, just one approach, like the supraorbital approach, everything that's been talked about, that approach, all the papers, all the things, what are your thoughts in the future of how, like, AI and whatnot, interpretation of all this work that's been done could help us kind of make some of these decisions, and maybe allow us to know what's not known and what we should go back to the lab
This is a
to?
very interesting question, and this was I think that's the reason also, as I mentioned, some chairmen are not interested. I think you feel it too. Some chairmen are not interested in neuroanatomy lab. They say, oh, this striker machine comes to the hospital to ICU, and this is enough. We don't need really to produce anything in neuroanatomy. I think the AI will help, and also the model of teaching anatomy, probably it will be the. And also, I mean, you are a very experienced surgeon. Sometimes you are doing surgery and so you see some structures that you don't know, like what are these structures? Just like this Tübingen line I showed you. I'm sure you see it all the time in your vestibular schwannoma surgery. So this was unknown until like 10 years ago that someone paid attention to it. I think if you have a research fellow available, you can always. So this is what happened to us. Like every 2-3 weeks, we sit together and say, okay, this is something that I have really question about it, and then see if do few cadaver dissection and see if you find something. Like example, it was a vein. Dr. Adam, my partner, was always showing us the vein that going emissary vein going to the when you retrosig approach, going to the bone, and he always told me this can be a landmark for 7 and 8. So then our research fellow started to dissect, and now in like 5, 6, 7 specimens, we see a constant trend of this as a landmark of 7 and 8 extradurally. So these are like some small things that when you are mindful to it during the surgery, or especially experienced people like you, that they do multiple surgeries every time, like after a while you see something different with other people that they do once a while. So I think that's another thing. New approaches like this trans-eyelid approaches, in the endoscopy, there is a lot of room, especially when you collaborate with ENT. We learn always new things, and it opens always a lot of new vision for us as a neurosurgeon to go to different areas. Also, this minimally invasive approaches, it was interesting. I was working with our fellow. It was a patient that had a radiation. It was a bicoronal approach, had multiple radiation, and the wound was so thin. He had a recurrence of the tumor in anterior part of the temporal lobe. So then we designed an approach to go half eyebrow and bring it down, and then we reached to that lesion. It was a small recurrence. We didn't want to open the wound, so we opened that area and we did this approach. And I told our research fellow, let's look at this and do multiple cadaveric dissection to see how is this approach and what area we can expose with this approach. I think having a research fellow in the lab and having meetings, constant meetings, like every other week or every 2-3 weeks, I think it's just brainstorm and brings the ideas. But obviously we have to add AI, we have to add this virtual reality, we have to add 3D anatomy, obviously, and all of this. But I think that's the summary.
Yeah, and that's my next question is, with virtual reality, with 3D printed models, how do you see those fitting into the educational component of today's resident?
Yeah, I think these are good, but really, I know these new models that coming, and they don't need ventilation. You can put it everywhere. You can bring it to room and you can dissect. But I'm sure you felt it. You are feeling this is different with dissection, right? It's good probably for medical student and junior resident, but for senior resident, they need really to see the vessels and to dissect. I don't think the value of like traditional old dissections in education goes away. I think the value is still there and nothing can replace it. So now we are going toward like making the blood into the vessels like carotid models and this stuff. I think it will be more role for these things um, rather than disappearing the cadavers. And it was interesting. We were in Yashagi. I'm sure, Angela, you saw in Yashagi Society, one of uh, the presenters from Nashville showed uh, like the computer starts from big computer in 80 something, then it gets smaller, 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 and now it's just a cell phone. You can do everything. But guitar has been always the same. So in from 80 something until now, it's guitar. Guitar is nothing has changed. And then he showed that yeah, like Yashar Gil technique is also the same over the time. So something really doesn't lose the value. I think one of them is really uh, cadaver dissections and working with the real cadaver. I don't think it will lose the value.
I have a very simple question. When you want to get a CAT scan of a cadaver head, like you can't just roll up to the CT scanner, right? Like, do you have a special research scanner? Like,
That's a good question. Uh, in big places that they have like a huge lab, like University of Pittsburgh, they have a special CT scan for cadaver heads. So they have an old CT scan that's just for cadaver heads. Um, in the new cadavers, when you order the heads from the companies, they can scan it for you and they send you with a scan. So when you order the head, they charge you a little bit more, and then they send you the disc of the scan, the disc of the CT scan and the head. So then you can use navigation in the lab and do all. In our CADA in the Mark Institute that we do our labs, they have a small CT scan in the lab, and then they do for all of the heads, and we put the screws before for that we don't lose because the skin gets very loose after some dissection. We put like 5 screws as a landmark, and then we like fiducials, and then we use them. We do a CT scan with them, and then we use them for the navigation.
and then, maybe this is because of my basic science background or like clinical research. We always talk about sample size. So if you're doing an anatomical study, like how many samples is enough to like define something or say that it's
Yeah.
common? How many skulls are you usually looking at, or how many brains?
For complex approaches, normally we do like 6 cadavers bilaterally uh, to measure and all of this. And then for like for this Tübingen line, like I showed, it was because it's easy to look at it. You can do even like 30, 40, 50. Because some institution they have like resources for different skulls. Then you can look at all skulls. But I think for approaches, normally 6 cadavers held bilaterally will be enough. 6 to 10, a maximum 10 really. So now, for Michael or Edward or you, Angela, what do you think about the interest of new generation of residents in like neuroanatomy knowledge, or like expanding their like thinking about new structures, like critical thinking about neuroanatomy?
Yeah, I mean it's funny, right? I mean, today they have more resources than they ever have. Webinars, papers, online, 3D stuff on their phone, and so it's almost too much information to kind of almost leave the mind wandering because there's always something else to read, and you really have to kind of push them to kind of think outside the box sometimes, I feel like, and really kind of say, well, just because we've done this, for 30 years or whatnot, it doesn't mean we have to continue to do it the same way. And I think it's if you finding a good paper on some of the old techniques too is also somewhat challenging, like a far lateral. I mean, yeah, there's been a lot of papers written by Dr. Hiros and things like that a long time ago, but to find a contemporary paper that really goes through the detailed nuances of some of the standard procedures are not really easy to find sometimes for the residents. But yeah, I mean, there is definitely a certain group. I mean, we have a large group of residents here in Miami, and there's definitely the people who want to do skull base and vascular, have that niche, have that curiosity, want to spend the time, in the anatomy lab, understanding the complex structures and trying to figure out why do we do things certain ways. So it's definitely not lost, but we definitely need to push it, with great talks like this and with resources like you have and others. I think it's critical for the field.
I would certainly echo what Mike just said. It's a critical aspect of training that I think is complementary to actual clinical practice. It's easy to get access to information and read about all of these structures and visualize it on a simulation or in text, but ultimately, surgical anatomy versus clinical anatomy or drawn anatomy is very different. So I've been doing a lot of really exciting work that I think will continue to motivate future generations.
I certainly think, going off what Mike said, there is some difficulty in residency, and I don't know that it's residence now, but probably overall, right? You're busy, you're exhausted, you're trying to check things off the list. So like maintaining that curiosity is hard for residents or anyone in training, I think, because you have to probably be awake, right? To be questioning things and thinking deeply about these approaches instead of just like, okay, what questions is Mike going to pimp me on tomorrow during this surgery? And like, how can I answer them right? As opposed to being more curious. And I think, it's our job as educators to try and foster that. And I think that's kind of a challenge to do sometimes when you're like, learn it my way, but maybe think about some other ways too, so you can be curious and think of different questions and different approaches.
Exactly. So as I said, it's interesting because I think for the hospitals that they have resources, having like experienced research fellow in the lab, as I mentioned, collaborating with clinical fellow, they can always brainstorm each other and then they can help each other. Clinical fellow is very, very busy, cannot sit and dissect, but if they work together is very nicely, they can answer each other questions. And obviously collaborating with experienced surgeon, I think that's the key.
Yeah, and I mean, I think that gives you it's like a little bit, the lab is a little bit of a playground, right? Like, what if I retracted this or drilled that or did that, as opposed to in, actual surgery, like that's not really tolerated.
That for sure, yeah.
What are your thoughts on making this standard in the curriculum of residents? Like, we've always kind of talked about that as, how do you build this more structured into the training so that it's consistent across, the country, about everybody getting the same exposure, making milestones and whatnot. But it's everybody's residency and training experience is so different. It's very challenging to kind of build something like that in. But I just, it's been talked about, I think, in every year of my training and every year of my academic career, we always talk about how, oh, we should talk about how we should make a milestone or training lab, or you should do this approach 5 times in the lab before you come to the thing. And it's hard to implement that. What are your thoughts on that?
I think these are the education part of the lab, right? This is different with the research part of the lab. But I think education part of the lab is we have to do education part of the lab, because anyways, when someone graduates, needs to know how to do OZ or how to do TERI or not. But I don't know, fortunately or unfortunately, now there's a lot of spine interest in resident, right? They don't want really to get very detailed to the cranial surgery. But I think it should be I think this striker machines does the job for evaluating of the resident if they can do the approaches and this stuff. But what we are talking about in research anatomy lab is like more deeper deeper than the education part of the lab. So, but I don't know if you feel also like cranial interest goes less and less because of the market or money or job situation. I think we need also to make it more appealing for the resident to continue on like a skull-based surgery fellowships and
Yeah, I mean, it's always in waves, right? I mean, I think that right now, it's definitely a little bit of a spine wave coming through our residency program, but we just finished with a large skull base wave that just finished. Angela and a whole bunch of other people. We had like 8 or 9 people in a row that just went into all skull base. So it definitely just in waves. But yeah, you're right. I mean, it does kind of go like that. It's interesting. Well, anyway, it's already been close to an hour. If there's no other questions from the crowd, I don't
yeah.
think I see
So
anything.
my last question is like
Yeah.
for you and Anja. So how do you see the appeal of the programs to invest money on labs?
I think that's tough, right? Because I think grant funding, like, you talked about industry funding and things like that, and those are achievable. I think it's, a question of where you can get grant funding to study things. Skull-based pathologies aren't common, and anatomy isn't, typically something where we see a lot of funding. So I think trying to find niche opportunities to apply for funding, but to convince people to invest space, right, which at any academic center is a huge premium, and money into a lab. I think the research productivity and the educational piece are really important, and using that to kind of get that bite of that interest. I
I know
think
your hospital has a big interest in like doing a lab and education and research for. So where is that coming from? Is it like a chairman interest, personal interest, or is a hospital interest, program interest?
I think it's all of the above. I mean, because we're starting like a bigger lab, we're getting set up. We had JP Almeida just started here, so that's kind of his task. He's getting that up and running, and it's a really exciting time because I think that's going to be good. But that did come with a lot of, the chair had to really take the reins and talk to all the folks and get the support and get the industry support and all of that. And I think it is, billing it as part of that tripartite mission that everybody likes to talk about. And also the innovation piece, I think, was something they used as well. Like, we can do innovation here, and everyone thinks innovation is super sexy. So if you throw that word around, people get really excited.
I think that the combination of these research productivities are important. Like you can focus on different aspects and produce more.
Okay, great. I think Edward, you have a little bit to say about what's next.
Yes. So thank you so much again, Hamid, for the outstanding talk. Just want to also remind everybody that our NASPS meeting is coming up February 13th, 16th in New Orleans. So please all join us for the fun. Next slide, please. And please save the date for the next of our series in the Advancing Scholarship webinar series, be January 22nd, same time as now, on how to enable multi-institutional data and registries. Going to be another exciting discussion as well. So thank you all for your attention tonight. This concludes the webinar, and I appreciate again, Hamid, for sharing your insights and your expertise. Thank you.
Yeah, excellent talk. Thank you so much again for your time.
Thank you.
Have a good night.
Have a good